Tell you the truth, I am not new to the Oman audience. It's my reunion with this kind of audience in Oman. Previously, I was working with another hospital here as a medical director and senior customer surgeon. Coming to today's program, 10th of last month, I should say, marked a turning point in the history of proctological services in this country. And I'm sure many of you are already aware of it. We at StarCare Burka launched a nationwide program, which is nothing but the Institute of Proctology. Probably the first one of its kind in this country, and maybe in this region as well. Why an Institute of Proctology? It is to provide a comprehensive proctological service. And what do you mean by comprehensive? Comprehensive is nothing but preventive, interventional, and rehabilitative. So we had a very good start, and this program is intended to enlighten the medical fraternity of Muscat about our intentions of spreading the best outcome, in proctology. As you know, proctology is a situation which is not liked by surgeons and patients alike, I think, primarily because, as I always say, the outcome of treatment, for example, a surgical intervention in conventional proctology, is almost as painful as the disease itself for quite significant time after surgery. So, at the Institute of Proctology, apart from having a very experienced, skilled and talented senior doctors joining together, we have introduced a very novel technology. It's not really novel, probably for this region, this is not being practiced in that high volume. Our cutting edge is the laser. And why laser? Many of you may be asking, thinking, why laser? I'm coming back to the same point, what I started with, the ill effects of treatment. That is the focus. And laser has proven that proctological surgeries interventions are as comfortable for the patient as it is with, or even more comfortable than many other surgical interventions which you do in general surgery. Patient come in the morning, they get operated the same day, and they go back home the same day. And believe me, they go back to their normal work life the next day. So now today we have a very eminent, as I told you, very eminent faculty here to have some interaction with you. We are indeed fortunate to have the presence of our Honorable Chairman, Dr. Sadiq Kodakad. Here, I welcome you, sir, onto the dais. Apart from being an eminent surgeon, eminent anesthesiologist, with a special interest in cardiac anesthesia, he himself has converted himself as a proctologist recently, because the whole program is his brainchild. So I would say it is one of his gifts to the country, I would say. So thank you, sir, for your presence and welcome. Now we have Dr. Alfred, who is experienced. Sir, welcome. Come, please occupy the dais. He is a very senior, experienced surgeon and a professor of surgery, working with one of the well-known medical institutes in India and as well as abroad, the KMC, Kasturba Medical College in Mangalore. Welcome, sir. Thank you. And last but not the least, the star of the day is none other than Dr. Habib Muhammad. He is, apart from being a very experienced surgeon himself, with special interest in proctology, he is our laser expert. He has been a trainer in laser proctology in India for quite some time now. Recently, he has joined our team in Verka. Welcome, sir. Thank you. Now, I don't want to waste much of time. I would like to invite Dr. Habib Muhammad to give his presentation. After that, we will spend some time on kind of discussion with the panelist, followed by a short question and answer session. So I invite Dr. Habib to make his presentation. Thank you.
Thank you, Dr. Sukumaran. And Assalamu alaikum. Good evening, colleagues. A warm welcome from the Starcare Laser Proctology Institute for Minimal Invasive Surgery for hemorrhoids, fissure, fistula, and pilonidal sinus. I would like to talk to you regarding the impact of laser on modern proctology and give you a look into my experience in laser and conventional proctology. Proctology usually deals with hemorrhoids, fissure, fistula, and pilonidal sinus. As we have many general surgeons, they would have noticed with the absence of some conditions and the presence of one condition. Usually, pilonidal sinus doesn't come into the purview of proctological conditions, but when we look into the purview of from the eyes of a general surgeon, we can include that in this proctological in the gambit of proctological conditions. And you might have noticed that prolapse, tumors, malignancies are missing. As you all know, in Oman, a general surgeon is not supposed to be dealing with those conditions, and so we have left it out. And what we can do, we try to do at the best. So I have included hemorrhoids, fistula, fissure, and pilonidal sinus in this presentation. As you all know, fistula is an abnormal tract that connects the anal canal or rectum to the outside. It can be simple, it can be complex, it can be low, high. And the treatment options conventional includes fistulectomy, fistulotomy, lift, now laser, and waft is also coming in the near future. This is a fissure in Nano. As you can see, there are two fissures, one in the 12 o'clock and the other in the 6 o'clock position. And the treatment options classically are fissurectomy, sphincterotomy, Botox injection, and laser. This is a pilonidal sinus, ideally treated with excision and a late open for 3 to 6 weeks where it granulates from below. Or you can do an excision and flap, and now laser and EPSIT is following. This is excision, then coverage with flap. You can see Z plus T and a Limburg flap, both done in Oman. Now we come to the most common condition, most common anal rectal condition, hemorrhoids. As you all know, about 50% of the population is affected in lifetime, and about 5% of the population is affected at any point of time. And though not, I don't have any statistical evidence, I find hemorrhoids and fistula and pilonidal sinus more in Oman than in India. The pathophysiology of hemorrhoids includes venous, arterial, connective tissue, and muscular. And we have to deal with all these aspects for a very good result. It may not always be, all the aspects may not be prominent, but depending, we have to take a call on all these aspects if you want a better results and least recurrence. The management of hemorrhoids include dietary and lifestyle modification, medical management, MPFF, calcium dubiscillate. Then there are outpatient procedures like rubber band ligation, injection sclerotherapy, infrared coagulation, which has been going on in Oman as in the name of laser. Infrared coagulation is many have marketed it in the name of laser for a long time now. And then comes the classical Milligan-Morgan hemorrhoidectomy and Logos stapled hemorrhoidopexy. And to my topic, laser. It's a well-known acronym, light amplification by the simulated emission of radiation, laser. And in general surgery or in proctology, we use the heating aspect of the laser, precise and targeted. And the heat does not spread beyond a particular distance. So we use that particular aspect of laser to treat the proctological conditions. And the heat generated in what type of tissue depends on the wavelength. As you can see that hemoglobin absorbs different wavelength at different rates, and water absorbs different wavelengths at different rates. Earlier 980 was used for proctological conditions, but then it is more absorbed more in hemoglobin or blood, but then water content is a better option, and so now we use 1470. But you can see that carbon dioxide is absorbed more in water, and it has a greater wavelength. But we don't use carbon dioxide. I will very soon I will tell you why we don't use carbon dioxide for proctological condition. And this is the effect of temperature on body. Less than tissues, so less than 40, we have enzyme induction, membrane disintegration, edema. 45 to 60, we have tissue damage. More than 60, we have coagulation, and more than 100, we have dehydration, carbonization, and vaporization. And our aim would be to achieve this range, above 60, below 100, in tissues, so that we will have coagulation and there won't be carbonization. So to achieve coagulation without carbonization, it would be our target. And this slide shows the difference. Earlier I told you this is carbon dioxide laser, and this is our 1470 diode laser. As you can see, carbon dioxide laser cuts sharply with minimal tissue damage, tissue reaction. And 1470 diode laser, it cuts bluntly with very wide tissue reaction. This aspect is very much needed for all the proctological conditions where you need less cut, coarse cut, and more tissue reaction. And this carbon dioxide can be used, laser can be used for very fine, precise cuts like ophthalmological conditions, surgeries. So we use 1470 diode laser to produce less cut with more tissue reaction. And these are the two types of lasers that we, fibers that we use. This is the radial fiber. As you can see, the rays are in a circle. And it can be used in any tubular structure where you want the heat to be distributed evenly in the circumference rather than in the center. And this is the bare fiber, just like any heating device where it has most heat in the center. So this radial fiber is used for fistulas, pylonidal sinus, and varicose veins. And our bare fiber is used for hemorrhoids and fissure. Actually, there is one more fiber which goes in between, like a conical fiber, which we can use for only for hemorrhoids, nothing else. So coming to my own data, for the last 3 years, I have been using lasers in India, especially in Kerala and in Oman. So I would like to present a total number of cases, which is 216. And within the past 1 month, it is 29 in Star Care. So these are the total number of cases. Fissure, fissure alone, where I did lateral sphincterotomy and laser lateral sphincterotomy. So total 8 cases. Conventional is I did lateral sphincterotomy. And when it came to fissure and hemorrhoids, that is the primary complaint was pain and fissure. But on inspection, we have the patient has hemorrhoids also. So I shift mainly to laser because I can deal with both the fissure and the hemorrhoids in the same sitting using laser. So I have 33 cases of laser and only 1 case of conventional, where I did a hemorrhoidal artery ligation and lateral sphincterotomy. Then hemorrhoids and fissure in nano. In that, main complaint is bleeding, mass, but when you examine the patient, there is a fissure also. So in that, the conventional method used was hemorrhoidal artery ligation in 3 cases and stapler in 16 cases and laser in 26 cases. And then hemorrhoids alone, the conventional method used was stapler, 22 cases, and laser, 50 cases. Then there are recurrent hemorrhoids, where a previous procedure was done, either stapler or laser or open hemorrhoidectomy, and it has recurred. And in all those cases, I use laser very effectively. Coming to fistula in nano, the conventional procedure includes mainly lift, where the internal opening is ligated and the track is excised. And I combine lift with laser, where the track is dealt with, where the internal opening is dealt with by lift and the track is dealt with laser. And recurrent fistula, only laser. Fistula in nano with fissure, only laser, because I can deal both with same laser. Then there is recurrent fistula in nano and fissure with fissure, that also I used only laser. Pylonidal sinus, conventional is excision, including Z-plasty and limber flap. And laser, where we use only laser, the radial fiber to deal with the pilonidal sinus. So it comes to total conventional 65 and laser 151, totaling 216 cases. And the results show that 80% of the patients with hemorrhoids choose medical management. They all want to try medical management, diet modification, etc. before choosing surgery. But whereas fistula and pilonidal sinus, it's the other way around, where 80% choose the surgery, and those who don't choose the surgery or laser is only because of the cost, means cost incurred. It's not, they don't expect, they all know that it has to be treated by surgery, but the cost factor and economic factors are the, or other factors like leave from work and all those things. The mean age was 45 years. We had a 13-year-old child with pilonidal sinus and an 85-year-old man with hemorrhoids. So wide range, but mean age is 45. Male-female ratio is 2:1, and the average hospital stay of laser in hemorrhoids and fissure in it's about 8 hours. They come in the morning, go in the evening. Pilonidal sinus, it's about 12 hours, and for fistula, I usually keep the patient, it's not actually needed, but I usually keep the patient nil per oral for 3 days, so that the intersphincteric incision that is made by me is not infected too often. The post-laser return to normal routine, hemorrhoids and fissure, it was seen to be 5 days, pilonidal sinus 7 days, and fistula in 14 days. So laser treatment of fissure in hemorrhoids, fistula, and pilonidal sinus has the advantage of lesser operating time, lesser skin trauma resulting in lesser pain, lesser hospitalization, and quicker return to work. And laser treatment has the options of general anesthesia, spinal anesthesia, or local with sedation as method of anesthesia. That is, if you want it to be take care, you can give local with sedation also. And laser treatment has comparable results with regard to relief of symptoms and recurrence. Long-term follow-up is awaited because it's a recent innovation, so or application in general surgery. So long-term recurrence rates are not available at present, but we have, during the last 3 years, the recurrence rates are very low or comparable to. And to conclude, if medical management alone is not effective, laser is the most suitable first-line treatment method for most types of hemorrhoids, fissure, fistula in and pilonidal sinus. And laser has made the treatment much more quicker and easier for both surgeon and patient. Stapler and conventional methods of management still have a place in the treatment protocol in selected cases. And video assistance, WAFT and EPSIT, WAFT for the fistula and EPSIT for the pilonidal sinus, are helpful tools for treating fistula and pilonidal sinus under vision in recurrent cases, mainly due to side tracks. As we all know, a picture is worth 1,000 words. So I'll show you some pictures. This was the oldest person I told. He presented with a grade 3 hemorrhoids. And this is post-laser. I've not even removed the sheets. This is a grade 3 hemorrhoids. It has to be reduced if it has to go in. And he's a very old man, 85-year-old man. And this is immediate post-laser. As you can see, the whole hemorrhoidal mass has reduced and it's visible even on table. And this is the worst case of hemorrhoids that I have managed. The patient came standing because he could not sit. He was bleeding, grade 4 hemorrhoids, 32-year-old man. And this is immediate post-laser. Same patient, immediate post laser. And it is the same patient after 3 weeks. Same patient after 3 weeks. So I think it gives you a visual gauge of the effect of laser in proctological conditions. And this is our team at Star Care Barka, our anesthetist, staff nurse, laser technicians, and our medical director and our consultant surgeon. And as you can see, I am missing because I wheeled the camera. And so thank you from all our team and laser proctological unit of Star Care. And I hope and wish that we get support from all of you so that your patients can get better care, most advanced care, and we shall always be in touch with you regarding follow-up and all those things. Thank you once more.
Thank you, Dr. Habib. It was a wonderful presentation. Sorry, I'm the only available anchor. So we go to the next session. It's a brief kind of panel discussion. So I invite Dr. Alfred to kindly share his views, his past experience with us briefly. Thank you.
Thank you, Dr. Sukumaran. Good evening, all. Dr. Habib has given a beautiful overview of how the laser has changed proctology. What I would like to tell you are 2 or 3 simple things. The first point is that whenever there are so many treatments available for a disease, it's because none of these treatments is ideal. What do we want in an ideal treatment for hemorrhoids, for example? We want this patient to have as painless an experience as possible. We want him to get back to his work quickly, and it should have the weight of evidence behind it. Of all the treatments which we have seen now, laser comes close to achieving these ideal, properties. Do we have alternative treatments? Of course, there are plenty of alternative treatments. The second point I would like to make is that every patient is different and we cannot blanket treat any patient. The treatment of hemorrhoids must be tailored to the patient. As you know, Dr. Habib mentioned, you can see the physiology. There's an arterial component, venous component, muscular component, and soft tissue component. And depending on which physiology is altered, we have to choose the treatment appropriately. So like he correctly said, there we have clear protocols and where we will choose which treatment. But again, I wish to emphasize laser comes very close to achieving most of our objectives. There are patients who will not be suitable, but they will be in the minority. The third thing is, because he used the word comprehensive care in the beginning, Dr. Sukumar said this, I wish to emphasize that we must educate our patients about the lifestyle they follow and how we can avoid this problem or keep this problem under control. Very often we get lost in the treatment of this and we don't emphasize enough on the preventive aspects of this. So we should educate our patients, especially those who come with early disease, and plenty of patients who come with early disease can be managed very well with simple lifestyle modifications, and they don't need to have surgery at all. Laser is not a gimmick. It is not a new tool, or it is not a new device. It's been tried out in a variety of conditions, and the main advantage of this is, see, we are transferring energy from a machine to the tissue. That is what a laser is doing. This energy transfer can be done with different types of equipment, with different types of energy. But none of those energy sources will come anywhere close to the precision, the accuracy and the exact dosage required as laser. So their laser is really has a phenomenal advantage. So I would not like to go on because there are time constraints, but what I would like to tell you is that any patient which finds his way to our Institute of Proctology, please believe me, ladies and gentlemen, this treatment will be tailored to the requirements of this patient. No patient is just going to get blindly lasered or blindly stapled. We will decide, we will follow protocols, and I invite all of you, please come and have a look at our systems. Please participate in the treatment of this patient. You know, it will be a joint treatment, and we'll take care of the patients together. Thank you very much.
Now, may I invite Dr. Sadiq to share his vast experience in researching into proctology, as well as also, please let us know some anesthetic aspect also. Thank you.
Thank you. Hope you don't mind. Okay. Let me stand up. Assalamu alaikum. As Sukumaran said, I'm not a surgeon and I'm not a proctologist. Normally I prefer to be away from that area and be at the head end. But we had to watch the pictures. I'm the chairman of StarCare Group, which means that I'm the one who started StarCare group of hospitals and medical centers and stuff, along with Mr. Nasr Batta, who is a group CEO and my partner and friend sitting there. He's not a medic. I don't know how he managed to watch through all those pictures. I was a bit worried about children as well in the audience. Anyway, my experience are two sides. One is as an anesthesiologist, as a practicing anesthesiologist, and one as a an organizer or an entrepreneur. I got exposed to laser proctology in India, in StarCare, Kerala, StarCare in Calicut, precisely in the northern part of India, northern part of Kerala, which is a southern state of India, if you're not familiar with India. We do a lot of, actually, that hospital started about 5 years ago, and we do a lot of laser, varicose vein, actually, endovenous laser. We have two vascular surgeons. And in the recent past, I've seen that we have two laser machines there, and we do approximately about 20-25 cases of laser varicose vein every week. Now I'm beginning to see that in the last 1.5-2 years, increasingly laser proctology work is happening there. I think it's about, I would say about 6 to 10. I don't know exactly the figures, but I don't always was a theatre list, but approximately 6 to 10 cases a week of laser proctology over there. Then I was working in Dubai, and I've started seeing the transformation of surgeons now completely moving from those who've been my colleagues, my friends who've been doing this are all transforming into laser surgeons. Those who are doing proctology. And I started seeing that some of them are now specializing and they're just doing only proctology. They've just left everything else. Presumably because there is a bit of a learning curve, and once they have learned that, they would like to continue doing that. Some of them do both proctology and varicose vein, or some of them just stick to proctology. Now, this is one of the reason when I came to Oman to live here, even though I've been behind StarCare for nearly 11 years, but I've never lived in Oman until about 6 months ago. So we decided to bring Dr. Sukumaran and others to boost up StarCare Vodka. Then we realized that we looked around for what are the gaps in the market, and one of this was laser proctology. And then we obviously looked for the technology and the humanware or the software needed for using it. And we were fortunate to find Dr. Habib as a friend of Dr. Sukumaran, who already has a lot of experience. I wanted somebody, with a lot of experience to start as an institute. Why we call it an institute? Because there are two reasons. And as Sukumaran said, to make it as comprehensive as we can, plus to start educating and to start, passing this information and be the knowledge resource and knowledge share focal point for proctology. That one is for the patient themselves, and for that we have already started two avenues. One, we have started as every Saturday free proctology seminar for the public. Anybody can walk in. Usually it starts around 11 o'clock to 12 o'clock. It's just picking up. People are just beginning to be aware. We only started this 1 month ago, but it's already the patients are really taking it up. So that is one on the awareness side, and the other thing is to have a presence on the web. So we are, I don't know what you've seen. Yeah, you can see that we have actually dedicated an entirely new website called laserproctology.com only for this purpose, mainly for the patients. But as we looked at it, we also realized that it's not just patients. A lot of doctors are keen and curious. So we are actually, it's building up. It's only just started. So you can log into and have a look at it. Do give us feedback and send feedbacks. And we are uploading a lot of videos, pictures, scientific articles, as well as for layperson article to know what is laser and what laser cannot do. Laser is not the answer for everything, as as Dr. Alfred Augustine said, but it is now becoming a common part of it. So, and also we have to be as scientific people. We need to be balancing our judgment, on the pros and cons of everything. So, and that will be what we will present on the website. So it's already started as an educational platform. At the same time, I would like to invite all of you to come and visit, train yourself, be part of the story, and take it out and experience yourself. And obviously, only by doing and doing and doing, you will practice makes it perfect, as they say. That learning curve is going to be there. Normally, in most countries and other places, you will have the machine experts themselves coming and holding your hand and teaching whenever there is a new technology, new gadgets, new toy. But unfortunately, in Oman, that was not the case. So we had to that's why we thought that we will start with the resource in-house itself. There are two surgeons, as far as I know, who has done more than 100 lasers. As far as I've done a full thorough research on this one. And one is unfortunately going back home, and the other person is here. So you make use of him, and they're all learning in the learning. Dr. Muhammad is here. Muhammad Al-Qasim is learning. A female surgeon is joining, and she's also going to be part of it. So it's and even Dr. Kim, as a gynecologist, who is sitting there, she's already supporting them, just because sometimes you need the lady connection with the for social aspect of the treatment. So now, should I just say one word about anesthesia side? Okay. You can, as you all know, that there are primarily three methodologies. General anesthesia, easy. The only thing is that you obviously go through to put either a laryngeal mask airway or an endotracheal tube with its own little bit of a post-operative nausea, vomiting, and other associated problems with it. But I'm not saying that GA is a bad thing. If GA in a good hand, GA using the right modern short-acting methodology is not a bad thing at all. But let's say it's easier to tell your patient that you don't want a general anesthesia or even a spinal anesthesia, and you can do with sedation, because it just makes them feel much more comfortable. In reality, if you want to do a good job of it, I'm not a surgeon, but I'm an anesthesiologist. But I've been on the other end of on the head end of the patient a lot of time. I would say if you want to be very, very thorough with the local anesthesia, either you do the pudendal nerve block or you do the dilute version with a lot of, more like the Timmerson's anesthesia, a lot of it, plus have your anesthesiologist using TCI, the target control infusion of propofol infusion. You will still need a little bit of ketamine or midazolam and things like that. There are doctors, there are surgeons who does it even without anesthesiologist presence, with the mild sedation, because if you're using deep sedation or even heavy moderate sedation, you do need anesthesiologist. Otherwise, on one or other day, you're going to be ending up in trouble, as you all know, but you don't want to do that, and you don't want to risk yourself for it. So if you're using as a pure local with light sedation, I know there are surgeons who does it, but I have not been taken part in it, partly because I'm an anesthesiologist. When we are there, naturally, they will be opting for it. But what I understand from those who have been experiencing that you are then having to compromise at some point. You may not be able to do everything what you want to do. So maybe in grade 1, 2 hemorrhoid it might be possible. And other cases you might, having to, either refer later or have them to come back later with more, facilities available. That's a little bit of my little anesthesia thoughts. The sedation technique again, if you are using the deep sedation with the local technique, you will have to relearn the positioning. Most of you surgeons or work with the proctology, with the lithotomy, with quite a steep head down and get the best position. But if you're doing the deep sedation without the airway management and local, then you'll have to be on a lateral position technique. It's very much doable. I know it's not, I think that it's not easy, but I have worked with more than 100 cases myself with another team in Dubai, and it's very much possible. There are a little bit of, like everything else, there is a bit of technique and that fine tuning to do, but it's very much possible. Thank you very much. I'm sorry I've taken a bit of more time than you allocated to me.
Well, I have been practicing conventional proctology for nearly 2 decades. And of course, a little bit of exposure to laser of late. When one of our first patients here in Barca was operated with laser, wanted to leave the hospital exactly 2 hours after the surgery. He got up out of his bed, and when he wanted to drive alone back to Sohar after 2 hours of surgery, that gave me quite a bit of pleasant feeling. I was just wondering what kind of feeling of those conventional surgery gave to the patient. So it is just to contrast. Now we have time constraint, but can we have a little bit of interactive session?
Thank you, Dr. Habib, for this lucid, attractive subject. Actually, I have 2 small questions. Would you like to go straight for treating fissure anal with laser, or you give a chance for medical sphincterotomy? Number 2, what is the role of laser in acute hemorrhoids? Thank you.
Dr. Habib, it might be worth you standing there because we are also on live on Instagram and Facebook. So.
Thank you, Doctor. Sphincterotomy, I would always prefer to do laser and surgical sphincterotomy because it is a spasm that is causing all the problems. And Botox can give relief for a time being, but later the muscle again goes into spasm. As you all know, it's ideally you can treat the acute fissure with medical muscle relaxation and diet control. But as you know, the dietary habits of people are very difficult to modify. And a very cooperative and actively participating patient can be managed with Botox, and then the diet, he should modify his diets and bowel habits, and then it can, there is no need for a sphincterotomy. But when we consider the modern life, where everybody doesn't want to change and but wants relief, laser lateral sphincterotomy is a very quick procedure. Very quick procedure means it takes just 5-10 minutes maximum, and the patient leaves the hospital, and the relief in pain is magical. It's just like switching off the pain. You switch off the pain, turn off the switch, and there is no pain. So the complete division of the internal sphincter without any other injury to the skin, that we can achieve with laser. And so I prefer in a patient who wants instant relief with not much hope of dietary and bowel habit change, surgical sphincterotomy, even open surgical sphincterotomy is the better method. And acute cases, as you have seen, it was a very difficult case. You would require some experience before you jump into acute grade 4 irreducible thrombosed hemorrhoids with laser, but it is possible. It is possible. As I told you, the patient had come, he could not sit in the vehicle, so he came standing in the vehicle, and we did the surgery immediately, and the relief you can see the difference. But you will have to tweak. Don't jump into grade 4 hemorrhoids with. Ideally, you start with a grade 1 or 2. Once you get the feel of it, then you can even deal with grade 4.
Dr. Habib, thank you for this information, but I think Dr. Salah asked about inflamed tissue. Can I use laser on inflamed tissue? This is a question. Also, I need to highlight about contraindication and complication of laser, if you can. Thank you.
Actually, we don't use it on the skin or the mucosa. That is the beauty of laser. There is no very little or no pain because the mucosa or the skin is not dealt with, or it's not affected by the laser. It is the venous sinuses that we deal with, and as you might have noticed, we look at a temperature of between 60 to 100 so that the blood boils inside, and apply ice to cool the mucosa, and it will apply some pressure, and it will be like a sticking of the inflamed inner surface to the internal sphincter. So just like what we say in staple, it is actually laser hemorrhoidopexy. It's not laser hemorrhoidectomy. It is laser hemorrhoidopexy. So we are not dealing with, or we don't apply the laser on the mucosa or into the skin or into the internal sphincter. It is the venous sinusoids that are dealt with, and the ideal aim is to break all the internal septae and convert that into one cavity and boil the blood just enough to burn the inner aspect. So it's not applied directly onto the inflamed mucosa or the skin.
Is there any contraindication for laser, please?
Actually, there is no contraindication, but it may not be, like I said, and all the other doctors said, it is not ideal to use on every patient. As you have asked, what are the complications? There are many complications. If the mucosa is very loose and flaccid, the coagulated blood can collect there, and it itself can cause pain and infection and all those things. So a careful selection of the patient is also a must. Even though I showed grade 3 and 4, it is not the ideal patient to start with. It is grade 1 and 2 which are most ideal and suitable for laser. And massive hemorrhoids, it's not ideal to start with, but you can deal with it. And like Dr. Alfred had said, you have to tailor your treatment to each patient, and you have to sometimes you have to deal with multiple aspects, like the arterial aspect, like the venous aspect, and the connective tissue aspect. All those things you have to deal with. So there are many instances where I combine two procedures. That is, I ligate the hemorrhoidal artery, and then that is a pure ligation. You can either Doppler guided or otherwise you can ligate the hemorrhoidal artery with a ligature, and then deal with the venous sinusoids with laser. So it is not one single shot for every patient, fitting every patient, and it's not a magic. It's only a tool, and we have to learn how to use it in the best way for the patient. For each patient is a different patient, and we have to tailor the treatment.
Excuse me. How do you deal with the skin tags?
I don't. I don't deal with the skin tag in that sitting, because then all the beauty is lost. You damage the skin, there will be pain. So that aspect of the skin tags, I clearly tell the patient that the skin tag will be there, it will remain, and if you really need to deal with it, we will deal with it in a second sitting. That is my approach. Because as you can see, I think the grade 4 hemorrhoids, skin tags remain even after 3 weeks. So, the beauty of no pain, daycare, everything is gone if you touch the skin tags. It will be painful. That, like I have told earlier, don't touch the skin, don't touch the mucosa, don't touch the muscle. Deal only with the tissue, deal only with the blood, venous sinusoids, and leave the rest. Don't if you do that, if you cut the skin tags, it becomes painful.
In case of the pilonidal sinus with the cavity, how do you deal with the cavity?
That is again another tricky situation. Pilonidal sinus, we actually have to curate out all the debris, and we have to clear the tracks, and then use laser. It takes some, it's it's ideal that the sinus is dealt with, but if there is an abscess cavity, then you will have to learn to ablate each of those, all the area, by moving the laser, and it is a blind procedure. And you have to move the laser fiber along the from the distal aspect to the proximal aspect, and it's a tricky situation, but you can do it. Even though in literature, pilonidal sinus has the least, has the maximum recurrence, we have had very good results with pilonidal sinus.
Maximum dose of joules you could deliver. Maximum dose of joules.
There is no such maximum dose. There is no such maximum dose. I go by the tissue reaction and my visual feedback. But how much can you give? That's like what I said. Laser has very precise. So I've gone even up to 6,000 joules, but those are for the pilonidal sinus and maybe multiple complex fistulas. But hemorrhoids usually goes down with less than 1,000 joules. Even big hemorrhoids.
If I may add a point to the pilonidal sinus, I think one of the important steps is to update the total systole, probably by curating as well as with energy, I think. What's your say on that?
The whole of the inside has to be burned. That is why I said it is a tricky situation. You are going blind, and we need to learn how to deal with it. Like in a fan-shaped manner, you move the laser from the distal part to the proximal part.
One more. How do you deal with the discharge after the hemorrhoid laser? We see patients complaining about a watery discharge. It keeps coming.
But in my experience, there has never been any discharge. Not even a single case of discharge after a hemorrhoid treatment.
I've seen patients coming up on the 10th day with a gush of blood.
Yeah, see, gush of blood is, like I said earlier, it could collect. in a loose, our aim should be pexy. So burn the inside and fix it to the internal sphincter so that there is no collection. But if collection occurs, then we will have to, it has to be dealt with like any other clots. You will have to let it out and then deal with it like that.
The question about pylonidal sinus and how to deal with the cavity. So one of the words used by Dr. Habib was, when you use a laser, it is essentially blind. So you can overcome this using a completely different technique. You could do an EPSIT procedure where you're using an endoscope and the whole procedure is done under vision. The difference is that Dr. Habib would use a laser to ablate the cavity or the tracts. In an EPSIT procedure, we'll use an endoscope, use vision, and use electrocautery, simple old-fashioned electrocautery to fulgurate the tract. So this is what we meant by saying we would tailor the treatment, because we cannot laser everything, we cannot EPSIT everything. We must look at the patient and see what the physiology of his disease there, what's the anatomy of the problem, and then address which treatment. EPSIT cannot be combined with laser, because when we do EPSIT, the fistulous tracts are filled with fluid and we are continuously irrigating the tracts. It will not be dry. So there are alternative techniques for every difficult situation. Thank you.
My question is just, how do a GP knows that this patient needs laser proctology? How he will decide? There should be, don't you think there should be a practicing section where GP should know that this point he needs laser proctology?
Ideally, it is the grade 1 and 2 hemorrhoids that are ideal for laser. The rest of the, but we see that patients coming with grade 1, that is just bleeding alone, is very rare. There will always be some mass. So, which treatment needs to be, unless it is grade 1 or 2, the medical and the GP can always try medical management. And if the patient is willing, they can try medical management. And it is not a cancer or something that which needs to be operated immediately. So failure of medical management and grade recurrence should be an indication for referral to a proctologist. And what method to be taken, let the proctologist decide. Don't it wouldn't be advisable to just advise them to do laser. Just they need to consult the proctologist and then decide on what is suitable for them. Or a surgeon. No, proctologist means I meant surgeon. We are all surgeons. GP can always try medical management with flavonoids, Dubiscillate, diet modification, and sit spa for 3 weeks, and it would actually give good relief. But if it recurs, then it is an indication that a permanent solution is indicated, and then what the treatment should be can be decided by the proctologist or surgeon. That would be.
As has already been mentioned by experts, it's always a combination of techniques tailored to the individual patient that results in the best outcome. That's what I believe. Even great, we have seen very good results on table. So what I'm trying to say is it's an intelligent combination of various techniques that results in best possible outcome. That is why it is proctology. That is why it is Institute of Proctology. That is why it is comprehensive proctology. Thank you so much. I hope there is no further question. May I now invite, Mr. Prabhakar to present his. Thank you. Thank you.
Good evening to one and all. Myself, Prabhakar. I'm working with Ibensina Pharmacy as a medical representative. I'm representing for Home Pharma products. And thank you, one and all, for accepting our invitation and being here with your valuable time spending for tonight's meeting. Home Pharma is a global Geneva-based company. They are the pioneer in manufacturing of biopharmaceutical products, particularly for the prevention of recurrent respiratory infection and recurrent UTI infection. Also, we have a strong base of vascular disease. Particularly in the vascular disease, we have a product called calcium Dubiscillate molecule. This is mainly indicated for hemorrhoids, varicose vein, as well as in the management of diabetic nephropathy, diabetic retinopathy, and diabetic peripheral neuropathy. These are the indications this molecule has been used. And thank you very much for providing this opportunity. And thanks to Dr. Habib, he has given in and around all the pathophysiology of hemorrhoid, all the mechanism, everything. Now I'm just going to present how the role of calcium Dubiscillate in the management of hemorrhoid. The main mechanism with the calcium Dubiscillate, the doxium acts through the multiple mechanism to improve the endothelial functions and their blood flow, thereby which significantly improving the symptoms of hemorrhoidal disease. And doxium has got anti-inflammatory and anti-oxidative properties, as well as which reduces capillary hyperpermeability and also which improves the endothelial dependent vasodilation. Doxium also reduces vascular endothelial growth factor induced effect and reduces edema. And with this picture, the blood vessel inflammation in hemorrhoidal disease, which causes leukocytes, then leukocytes to roll and stick to the endothelium, which leading to increase the vascular permeability and damage to vessel walls. Thereby, which offers increased vascular permeability, results in vessel leakage and swelling, which leads to doxium due to the, which has got anti-oxidative as well as anti-inflammatory action, has been shown to reduce microvascular hyperpermeability, thereby which reducing swelling and discharge in the anal canal. The inflammation can also result in blood stasis and clot formation. Thereby, doxium has shown to reduce the blood hyperviscosity and platelet aggregation, which improves the blood flow. So, doxium may also prove endothelial dependent vasodilation by promoting nitric oxide synthase, thereby which offers inhibit the endothelin 1, which leads to thereby strengthening the blood vessel walls. The vascular endothelial growth factor may exacerbate hemorrhoidal disease by causing neovascularization, vasodilation, as well as an increasing of vascular permeability. So doxium, which inhibits the vascular endothelial growth factor expression and downstream pathways, also helping to maintain integrity of the microvascular system and reduce edema. As I discussed earlier, the doxium acts through multiple mechanisms of action to improve vascular tone, endothelial function and blood flow, significantly improve the clinical signs and symptoms of the hemorrhoidal disease from day 2 of the treatment. So, when the patient is suffering from hemorrhoid, particularly when they are suffering from pain, discharge and bleeding, what could be the treatment we can provide? Particularly for the first and second degree of hemorrhoids, we have the option which is called calcium Dubiscillate. This patient, after taking the calcium Dubiscillate, within second day of the treatment, to release from pain, discharge, and bleeding, the patient has got the benefit. We have conducted the clinical trial. It's a double-blind controlled study randomized clinical trial comparison with micronized purified flavonoid fraction along with calcium Dubiscillate. It's a comparative study which was published in Sarabhai et al. 2001. Within 2 days, the symptoms relief, almost the pain has been reduced by 56%, whereas the inflammation has been reduced by 69% when compared with MPFF. Also, further improved after 4 weeks of the treatment, the pain has been reduced 94% and the inflammation has been reduced by 97%. Also, doxim reduces discharge, edema, and pruritus within 48 hours, even further after 4 weeks. The quick symptom relief with the doxium within 48 hours, almost discharge has been reduced by 80% and edema has been reduced by 69% and pruritus has been reduced by 65% when compared with MPFF. Also, after 4 weeks of the treatment, the discharge has been reduced by 100% and the edema has been reduced by 91% and pruritus has been reduced by 87% when compared with my MPFF like Daflan. There is no significant difference between two groups, both are equally effective. Only the advantage with the doxium is just off of the pill. Instead of taking 6 tablets of Daflan, just doxium has to take only 3 tablets. This is just to lower the pill burden. That is the main difference, but significantly both are equally effective. Also, the bleeding has been reduced within 48 hours, almost 66%, and at the end of 4 weeks, which has reduced 92%. With the doxium, that's the Daflan, it's 95%. Another study we have conducted, the doxium reduces significantly symptoms in acute attacks of hemorrhoidal disease. This is study conducted by Mentis et al. 2001. Providing calcium Dubiscillate along with high fiber diet, which provide considerable symptomatic relief for the patients. Almost the success rate at within 2 weeks, 97%. With calcium Dubiscillate, it's a control group is only diet alone, whereas the calcium Dubiscillate along with high fiber diet. The treatment offers 97% at the end of 2 weeks. Also, we have provided a complete range of calcium Dubiscillate, oral as well as topical ointment. So it will provide complete range for the suitable for patients. We have 500 milligram capsule, it's available, and we have the Doxyprop ointment. It's a combination of calcium Dubiscillate with the lidocaine, as well as Doxyprop plus with added benefit of dexamethasone acetate 0.025% and local anesthetic along with calcium Dubiscillate. Also, bleeding cessation and lack of severe anaitis within 2 weeks with the oral as well as local application topical ointment. Almost the success rate is 98% with this. This is just calcium supplement, calcium Dubiscillate along with high fiber diet. Also, the relief of symptoms with a significant improvement in inflammation with the oral and local calcium Dubiscillate. The success rate is 86% at the end of 4 weeks treatment when compared with control group. This is published in Bhaskar et al. 2013. So, the treatment with calcium Dubiscillate, which enhances the patient output, and doxium is a microvascular protector which improves symptoms such as pain, discharge, and bleeding within 48 hours. Also, doxium reduces inflammation, edema, and pruritus with a lower pill burden when compared with other venoactive drugs. Also, doxium has helped more than 60 million patients, almost more than which is available in 50 countries with the same brand name doxium, which has got a favorable safety and tolerability profile similar to placebo. So, whenever the patient suffering from hemorrhoid, particularly in the first and second degree of hemorrhoid, kindly you can go for with a doxium capsule, calcium dubiscillate, and topical ointment, doxiproct and doxiproct plus ointment available. The dosage, recommended dosage is doxium is just 1 capsule 3 times daily for 2 weeks, maximum of 1 month. Whereas topical application, doxiproct or doxiproct plus just 2 to 3 times daily, maximum of 2 weeks, and depends upon the severity of the condition. Thank you very much for your valuable time.
Thank you, Mr. Pro.
Thank you.
It has been, I think, a very fruitful interaction today, this evening. Personally, it gives me great pleasure to have reunited with Muscat Medical Fraternity again after a short interval. Thank you so much for your attendance on my personal behalf. Feel free always to have interaction with our fraternity in Star Care Varka regarding any aspects of surgery other than proctology. And now, may I invite Mr. Nityananda, our Chief Operating Officer and Unit Head, to give the formal word of thanks. Thank you.
So good evening to all. So firstly, thanks to all the doctors here who came here to attend this CME on laser proctology. So thanks to everyone from Star Care Varka and the Star Care Group Hospitals. And thanks to our eminent speaker today, Dr. Habib Muhammad, for our informative talk on laser proctology. Thanks to our chairman, Dr. Sadiq, who gave the future for the laser proctology in Star Care Group. And special thanks to Dr. Sukumaran, the medical director and the consultant general surgery, to Alfred Augustine, consultant for general surgery and laparoscopic at our hospitals. And special thanks to Home Pharma for supporting us in this event, and our team behind the show, the marketing and other team members who have come here for this one. So dinner we have on the ground floor at the cafe here, Olive Cafe. So please join us for the dinner. So once again, thanks to everyone. Thank you all.
What's the point? What's the point?
Doctor, keep up.
Where is CEO? Call Mr. Nasser also.
Nasser. Was there anybody in the